Hello again, welcome back. Hope everyone's feeling recharged and ready to get involved in more content from our upcoming speakers. On our next panel, we'll be discussing the importance of build diversity within the NHS estate. Many people are navigating a building and feeling comfortable within it for granted. However, for those who are not neurotypical, this can be problematic. Between 15 and 20% of the population is thought to have neurodiverse needs. In October last year, the British Standards Institution published PAS 6463, the first of its kind national guidance to consider accessibility for a neurodiverse population. So, to explore what can be done across the estate to meet the needs of those who are neurodivergent, let's welcome Alexia Gica, Associate Lighting Director at Bureau Happold, Jill Corbin, Associate National Development Team for Inclusion, Dr. Chris Ince, Consultant Psychiatrist and National Specialist, NHS England, Simon Taylor, Estate Strategy Team, NHS Property Services Healthy Places Programme, and Derek Woods, Estates Lead, Estates Delivery Team, NHS England. Please do carry on submitting questions. I'll ask our panellists as many as I can, and there'll be a prize for anyone spotted. I've actually changed outfits because of the sub-zero temperatures, as has Dr. Chris, because he was strobing. So you've got a different shirt on, Chris. It's really lovely to see you all. This panel we're doing a little bit differently because I have 6 questions to put to all of you, and you all sit with different viewpoints. So we're doing this a little bit differently. But first of all, I thought it would be really nice for our audience just to have a very brief introduction, given the fact we've got 5 guests. To you, what you do, your role, and how you fit in for context purposes. And Jill, I gather you're autistic yourself, and you play a key role in inclusion. So tell us a little bit about you, if you would.
Thanks, Helen. Yeah, I'm Jill Corbin. I'm an associate with the National Development Team for Inclusion, but I am also a director of a company called Neurodiverse Connection. And I have been working on sensory environment reviews, and with the estates team, I was the lead author of a report called It's Not Rocket Science into inpatient sensory environment, and also led on the development of the NHS sensory friendly ward principles.
Fantastic. Well, Derek, as well as being a States lead at NHS England, you describe yourself as a professional northerner. That's good, because I am. Dad of 4, and you have autism in your family too.
Yes, 2 of my children are autistic, and I've recently come to terms to my late diagnosed autism myself. But involved in estate strategies and involved in delivering capital programs. So very much connected as to how we deliver those with this in mind.
Brilliant. Chris, consultant psychiatrist and an autism lead, I gather.
Good afternoon, Helen. So yes, I'm a consultant psychiatrist working within services in Newcastle, previously within a National Referral Inpatient Autism Service, and I'm part-time seconded to NHS England as National Specialty Advisor for Autism. And I suppose in terms of declarations and disclosures, I have a diagnosis of ADHD as well.
Okay, and then we come to Alexia. Alexia, what do you do for Bureau Happold?
Good afternoon, everyone. Yes, I'm sitting within Bureau Happold lighting team. Bureau Happold is an engineering firm. We've obviously been undertaking quite large projects in all types of sectors, but we have a keen focus on the healthcare environment. We see a very close interest between neurodiversity and lighting, as it has physiological and psychological effects in all types of people. And it is actually a pleasure to feel that through our work and through our jobs, we can make people feel a bit more comfortable in their sensory and spatial environments.
Oh, that's so rewarding. And I think Mark, our final speaker before lunch, who was talking about, he's an architect, all the design thoughts that had gone into a cancer unit he was designing, just really brought it home as to how important it is that everybody feels welcome and comfortable too. And Simon, I noticed from your bio that you've got decades working in the real estate sector, 5 years in the NHS. And I'm guessing you bring learnings from other sectors to what we're talking about today.
So I'm Simon Taylor. I'm an estate planning, estate strategist. I work for NHS Property Services, 10% of the NHS estate. So the NHS has got multiple our business property services private community estate. So I work closely with ICSs to help them plan our estate to meet their, and that obviously leads into projects. I think the Healthy Places program is mentioned in the bio. So that's kind of our way of managing all the large we have. And yeah, but subject, I first bumped into these guys earlier this year, and as we'll hear, they've got lots of passion for it. And as a property professional, we do anything to improve buildings, then we'll try to do.
Yeah, it's so important. Well, we'll get cracking on our 6 questions. So, I mean, I'll ask you all, but maybe Jill, maybe you can kick us off. Describing the sensory challenges experienced by autistic people and how the built environment affects them, and perhaps you have some personal experience to add in there too.
Thanks. Yeah. So I guess the obvious starting point is that everybody is different, and everybody has an individual sensory profile and individual needs. But within that, there's definitely some learning and some general principles that I think we can take that are going to be really beneficial. So often autistic people have hypersensitivity to their external senses, so particularly touch, taste, smell, sight, and sound. And as well as being able to, for example, hear more in detail, we also struggle sometimes to filter and habituate. So, for example, if there was maybe not today on this snowy day, but if there was a lawnmower outside cutting the grass, you might hear that and be processing that all the time. And for those of us who can only process one thing at a time, very quickly our processing stacks up and we start to get delayed processing. So in addition to our hypersensitivity or our heightened sensitivity for our external senses, we're often also hyposensitive or less sensitive in our internal senses. And so we're getting a lot of information, from sound or from bright lighting, for example, and it can make it even harder to know what's happening inside. So where is my body in space? Am I upright? What am I feeling? Do I need the toilet? Am I hungry? And so it can be very, very difficult for us to regulate and to stay well. An example of that in a healthcare environment, I have auditory sensitivity and also visual sensitivity. So I really struggle with LED lights. And I went to my GP surgery and there was a radio on, which is challenging. There's a lot of hard surfaces in healthcare environments, so there's a lot of echo. There was people coming and going. The lights were on, it was very bright. And I thought, I logged in and I thought I can manage this for 2 minutes. And then the 2 minutes, there's the screen that comes up that says you'll be seen in 2 minutes, and 2 minutes came and went. And I realized it was one of those things when they say it's going to be 2 minutes and it's not. And I couldn't manage. There was too much to process. There was too much uncertainty. And that's one example, but this is so important. We saw the leader report come out today, and that said the median age of death for autistic adults without a learning disability is 55 years.
Oh my goodness.
Compared to over 82 years for the general population. So it's so important that we think about accessibility of healthcare environments.
Absolutely. Derek, do you want to build on what Jill said there?
Yes, absolutely. And I think Jill really hits the point there about that information overload, and information overload from so many different sources, whether it's hearing, sight, and everything else that goes with it. And a really good example of really bad practice is I was in a CAMS unit with my eldest when my eldest was about 14. And I found the room really, really, really oppressive. My 14-year-old, who was there for the first time seeing mental health services, was in a room with high windows, really stark floors, bare painted blockwork walls. Again, a radio playing from a television set, right out of reach of anybody to change it or turn it off, and flickering fluorescent lights, not LEDs. They've not replaced them yet to that point. It was flickering fluorescent lights, and it just added to the anxiety. And it was just that space was just so wrong and could have been so very, very different.
Which presumably is where people like you come in, Alexia, very aware. You mentioned lighting in your introduction, and I know that certain shops, I can't bear fluorescent lighting. So I would imagine it has a massive effect on on people like Jill and and Derek's family.
And it is what Jill said, that obviously we sometimes we can't really avoid going into these healthcare settings. But one thing we always have to think and have in mind is that a healthcare setting is a healing environment. And if it doesn't have the right factors and the right sensory considerations in order to facilitate healing and actually do the opposite, prolong that, then it actually doesn't service people's needs. Out of all places, if any one sector should be inclusive, it is actually the healthcare sector, right? Because people don't necessarily choose to be there, but they have to be there.
Well, I think that's a nice time to bring Chris in. Chris, it is a healing place, isn't it? It's, we look to people like you to make us well, and the environment is part of that.
I have a slight wry smile, and I think Jill will understand why. And that I think the difficulty is that a large number of healthcare settings that we have at present are not necessarily healing places for autistic people. I think just in terms of perhaps a context. So there are approximately 24,000 inpatient mental health beds across England and Wales at present, of which perhaps 10 to 15% of that population are autistic, which is a significant number. We see autistic people are 8 times more likely to present to services with suicidality in any year. So therefore, the data shows that they are overrepresented in contact with crisis mental health services, general practices, and also into urgent and emergency care settings, so accident emergency departments. And also what we see is that there is a lower uptake of health screening. And I think if you take autistic women as an example, then the breast cancer screening rate is approximately 13% lower than it is for the general population, which contributes to aspects of mortality and morbidity, i.e. if people are not accessing care effectively early, not accessing preventative care and screening, then clearly their health outcomes will be worse. I think if we take the specific example of emergency departments, then they are noisy, busy, unpredictable environments where you have an unpredictable population, an unpredictable length of stay. And so if an autistic person presents in crisis, and be that related to autism, mental health or physical health, then the difficulties and the challenges of processing that environment will therefore also further lead to difficulties in them being able to effectively communicate the reasons for their attendance, pain, symptoms, and so it then has a knock-on impact in their ability to effectively access treatment for whatever reason they're there. So I think the issue of sensory environments and the build quality is crucial, both in terms of new builds but also in terms of retrofits. And I listened to the presentation this morning, and because if you don't have accessibility, people can't access and people can't receive healthcare. And obviously the fundamental aspect of healthcare is the ability to see people for that process to begin.
Simon, is this all stuff that you're aware of at the estate's strategy team and trying to improve?
Yeah, in broad terms, I would say yes. I'd say I'm fortunate enough to meet Jill and colleagues earlier in the year, and the reason I'm here today is because it's an interesting conversation. It's a difficult conversation, if I'm honest, for an estate planner and an estate owner, because you think, crikey, we're making this, our estate's having this detrimental impact on our residents of the country. We have to mind ourselves that the NHS, generally speaking, has got an aged estate. There are many buildings in the NHS that are older than the NHS, and that poses lots of challenges. We don't build. That's the other thing. There's lots of new infrastructure coming. So what do we do? And I think that is make best use of what we've got in terms of the buildings we have, the capital we have, the adaptations we can make in. I do think one thing that is a big opportunity is LED lights. Jill, not from of LEDs themselves, but the fact that they are a spend opportunity, and therefore we'll see a lot of programs replacing lighting with LED lighting. So if we can get that specification right, that start to see some degree of scale across the NHS.
Jill, I mean, I think lighting is definitely an area, isn't it, that can make a difference, and we can also talk to Alexia about that as well. But what else makes could make a big difference?
I'd signpost people to the NHS sensory friendly ward principles. I think they're a really, really good, clear starting point. And some of it is around adjustments that we make to practice, and some of it is around adjustments that we make to the environment, and some of it is about adjustments that we support and empower people to be able to make themselves. And ideally, we're going to be seeing a combination of all of those. But I think for folks who are in a position to make changes, so to lighting, like, let's get it right. Let's not retrofit like for like, because that is very, very likely to be harmful and detrimental. So the lighting is a really, really critical one, and I know there's a lot of funding going into that at the moment. Another really big one is around alarms, noise, and echo. So particularly in inpatient services, alarms are intended to alarm, like they are intended to create a nervous system response. And, it's going through your system every time it goes. So, we can think about that in inpatient services and move to silent alarms, but we can also think about the beeping of machines and equipment, and being able to turn things off or down, making quiet spaces available, asking people about their access and sensory needs. There's a hospital, I can't remember the location, Chris, but it was the one used in the video for the sensory friendly ward principles, who have packs where they give, like, that it's not noise cancelling headphones, but it's more like the ones you would use on an industrial site. Make those available. So, there are definitely small change. Closing a door behind us rather than letting it slam shut, for example. There are changes to practice. There are more significant changes to buildings. But I think awareness is really key.
And Derek, when Jill's talking there, I mean, I think what strikes me is what's better for neurodivergent people is probably better for all of us. I think when we're in a hospital and we're not well, the beeping of alarms and all that kind of thing, or the smell of strong chemicals and cleaning fluids, which I know is something else that, perhaps you're more sensitive to, but I feel really sensitive to all this too. So if we put these measures in place, perhaps we're building better space for everybody.
Exactly that. We are building best space for everybody, because no matter who you are or what background you've got, when you're in a healthcare setting, it tends to be a period where you're anxious, and it's dampening that anxiety for people. Now, people with autism, that anxiety is multiplied. So then just it's doing things to dampen down people's anxieties. So all the things that Jill said about noises off, but also about predictability. And that's not just predictability about how you flow through a healthcare building. It's also, as Jill said, practice as much in terms of predictability as well. Is if you're chopping and changing appointments as to where they are or who they are with, is ample notice, or with autistic people to avoid it as much as you possibly can. And it's that predictability of your journey through the healthcare system that's really, really important to help with anxiety.
What adjustments are you seeing, Alexia? What that are really making a difference?
So I would start actually referring back to the sustainability session before lunch, and the fact that, one of the early wins that have been identified is just to change fluorescent to LED. But I wish it was that easy. I think from the lived experience you're hearing today, you come to realize that it takes a little bit more than that, and it takes a bit more refinement of that specification. And whether that comes down to making sure that the flicker rates are lower than what a normal fitting would have, or an industrial fitting would have. Embedding flexibility and controllability of the lighting is almost a key factor here. We heard that glare is one of the big aspects that are causing this distress in people of neurodivergent profiles. And you know, when you're embedded lighting in a building, light is actually invisible until it hits a surface. So it is very much reliant on what the surface is, and that's where it works together with the designer of the whole building. And there are obviously practices and methodologies that we can employ to make sure that light is diffused, that it's smoother, that it's easy to process, it's not direct, it doesn't cause a lot of shadows and harsh contrast, and it has the ability to switch off, because sometimes people just can't bear any lighting.
Yeah.
And there is absolutely no controllability in healthcare settings, even in inpatient environments. So yeah, this would be some early wins, but I'm afraid that without user consultation and experienced technical and design teams, it is actually, the result could be at risk.
Yeah. What changes would you like to see, Chris, from your perspective, but also from your patient's perspective?
I think there's a number of aspects. I think just picking up on what Alexa and Jill have just said, there are simple things that can be done. I mean, wall treatments are really important. You know, if you have lighting but you have high gloss finishes on walls, you will immediately create glare. If you have matte finishes, then it is easier to process as an environment. Clear signage, yes. The transitions through from one area to another, predictability. There are many things that are complicated, but there are also many things that are simple. And I think, as was said before, actually, if by making an environment more accessible to people with neurodiversity, we will not impact negatively on the experience of neurotypical people. In fact, they're probably much happier with it as well. I think there's small changes that can be done. I suppose if you take the example again as emergency departments, and it's Leeds Royal Infirmary that have sensory bags, and there are a number of other hospitals which have very local solutions to this, in terms of fidget toys, ear defenders, sunglasses, things that people can access. But it's about acknowledging that in any sphere of health, there is a high likelihood that at any one time there will be a number of people within that environment who are autistic or neurodivergent. If you have access to a quiet room within an accident emergency department, if you have access to the ability for the person to make people aware. I mean, we have hospital passports, and the evidence demonstrates that hospital passports unfortunately are not that effective. But that's more about the fact, and for those that don't know, hospital passport is essentially setting out a person's preferences, sensory preferences, communication preferences, diagnosis, medication, so they don't have to communicate that information themselves at a time of distress. But the difficulty is that a hospital passport is only effective if a service can make the adjustments that are required. So some of this is about environment, some of this is about staff, some of this is about workforce. We must be mindful of the Health and Care Act 2022, which sets out a mandatory duty for all health and social care staff to be appropriately trained to their role in learning disability and autism. So there is a statutory obligation here. And obviously, there are further statutory obligations in legislation, dating back to things like the Equality Act. So there are these frameworks in which change can be examined, can be sort of pushed forward. But I think the other thing is that actually having a consideration of the issue at the design stage or at the refit stage, actually having some consultation with someone who knows something about it, but actually even just being mindful of the fact that actually this is something we should be considering then I think that for me would be almost the first and the most significant win.
I mean, Simon, there obviously are small wins that can be made, but I would imagine there are some fairly big challenges with putting adjustments into practice. I mean, even when we were just talking about paint there, it's not like being at home where you can get a tin of paint out and change a wall colour. I'm imagining within the NHS there's frameworks and processes you have to go through. So I guess my question is, what are the challenges in trying to make these really positive adjustments, bringing it into practice?
Yeah, well, I think the fact we've got thousands building and then the budget to make wholesale change. The one thing that talked about on previous calls was the need for policy direction on this. So there's lots of strong documentation within the NHS, but having reviewed it only recently, though it says the right things about some of these treatments, it doesn't go as far as so I think there's a need to look at policy, because I think getting policy top down means that people will follow it rather than it being left to local decisions. The second thing I would say that where we have got projects, we need to bring this conversation into the projects and engage the right different communities to get different perspectives. As planners, we like to think we know about buildings, but buildings are about people using them. So we need to get the user looking at it from the inside out to make sure it works. Try a few things, get some good case studies, promote the good evidence with our colleagues. And then something I'm quite passionate about is actually going back to the bit we've done something with and doing some form of occupancy evaluation to talk to people. How is it working for our workforce? How is it working for patients? Did those things that we set out to do have impacts and learn from it? So I think there's a very big, strong piece of policy here, a big piece of engagement as well. And again, going back to the point I made earlier, that's why this is such an interesting conversation, because we want to make the right decisions when we make interventions with our estate. We don't get that many chances. So when we do make interventions, we need to make the right ones.
Absolutely. Derek, I'm just wondering, we're coming to the end of the panel, so I'll try and squeeze a couple more bits in, but is there much training available on this so that people in the audience can have somewhere to go to? Are there any practical resources that might help?
Well, I don't know whether we can share some of the links that we'd already provided in terms of what training is out there and what is available.
Yeah.
But if I could just pick up on the point that was just made it in terms of policy, perhaps we could revisit existing policy, because you remember 25 years ago or more, we're making all those adjustments for the Disability Discrimination Act. We made many, many adjustments to premises for visible disability, but we missed a trick at that point not to make those changes for invisible disabilities. And it's just, what can we do to revisit that legislation to see if that empowers us to say this is now a must?
Yeah, absolutely. Jill, I'm just wondering, again, briefly, because we're near the end, and it's just a couple of other points I wanted to squeeze in, but what about people in the audience on, what can people do in the short, mid and long term to try and improve things for autistic people in the NHS estate?
So we've shared quite a few links. I'd really encourage you to take a look, raise awareness. I think speaking about this really helps. There is some work happening nationally that we'd welcome linking in with you about. Have a conversation with us if that would be helpful. But I think the really key thing is consider we have a different sensory perception. Work with us, ask us what we need, and educate yourself so you can be confident in having those conversations.
Alexia, I would imagine it's a privilege and an honour, is it, to be doing the kind of work you're doing and seeing the difference that you can make?
Honestly, I've been working with Jill the past 2 years, and I've learned so much. And I think there is a lot to learn from each other. We heard that in the previous session as well. Just the acceptance of we are all very different, and we shouldn't really make that a barrier, but celebrate it.
And just finally, Chris, in Jill's words, nicking a line from Jill, it's not rocket science, is it, to make a very big difference for a lot of people?
It is not, and as I said, I think just the starting point is the consideration of the changes that can be made, and if there is a refurbishment or a redesign, then consideration being given at that stage, because it's so hard to go back and revisit, particularly from the point of materials, budgetary constraints and everything that goes with that.
Yeah, well, it's been fascinating to talk to you all, and really interesting that you're all seeing this conversation from a different viewpoint, and all your thoughts linked together so well. And it is good that we're talking about it, and on a platform like this as well. So hopefully those, what you said today, those views can be shared. Yeah, it's been a great subject to discuss, and I hope I'll see you on future NHEs. So thank you very much to Alexia, to Jill, Chris, Simon, and Derek for a great discussion on what really needs to be done to build diversity in estates and to make sure that everyone feels welcome, comfortable, and included. We'll take a final break. Please make full use of the speed networking function, as this is your last opportunity to do so. I'll see you back here at 3:10.